Greetings, Chapter 11, Inflammation. In this figure, what they're attempting to do is they are attempting to show you a number of diseases that we will encounter this semester and how they lead into the inflammatory response. So if you go over here, we have asthma, pneumonia, and ARDS, acute respiratory distress syndrome, and they are going to lead to problems in oxygenation, and that's going to trigger the inflammatory response. Over here, Crohn's disease, ulcerative colitis, they are gastrointestinal pathologies. They are involved in pathological elimination, and that is going to be the trigger into the inflammatory response. Here you have rheumatoid arthritis, thyroiditis. They are autoimmune diseases, and they are going to be aberrations in immunity that lead to inflammation. And here you have stroke, heart failure, myocardial infarction, and atherosclerosis. And they are problems with perfusion, blood flow. And that is going to lead to inflammation. Obesity, diabetes, metabolic problems leads to inflammation. And last but not least, ulcerative colitis or Crohn's disease that are problems with infection that will also lead to inflammation. So as we go through the semester, inflammation is going to be appearing and reappearing, and this is the reason why. You have two types of immune responses to these types of insults. One is called innate, and the other is called acquired. So a little bit about innate immunity. As the name implies, it's something that you're born with, and it is your first line of defense against invaders. And what can happen is you can have physical barriers so that the microbes cannot get in. Your skin, it's dead, it's keratinized, so it's waterproof. So if any microbe lands on it, it's not going to be able to enter the body. So these are physical and there are chemical barriers so that the microbes cannot get in. If they do get in, and I'm going to use an example of if I picked a knife up the wrong way, and that is going to cause a wound in my hand, I'm going to bleed, I'm going to clot, but microbes have fallen into that wound area, and I am now, or my immune system, my innate immune system is now going to mount a response to eliminate or remove those microbes in the wound site. So that is going to be inflammation. And inflammation is a complicated process which begins with phagocytic white blood cells called neutrophils that will be able to leave circulation and go into the wound area and eliminate any damaged tissue, dead tissue, microbes. The inflammatory response have 4 cardinal signs: redness, swelling, heat, and pain. More about that later. In contrast, acquired immunity, as the name implies, you acquire it. You're not born with it, you acquire it, and you are born with the essential cells involved, but that what will first happen is the body will try to eliminate it by innate means. If that does not succeed, then you're going to go into acquired immunity. It's also known as adaptive immunity, and it is continually refined through the life of the individual. This is important, the specificity. The specificity of acquired immunity is going to be pathogen specific. And when the innate immunity fails for whatever reason, and you then evoke acquired immunity or adaptive immunity, then when you do that afterwards, you will have memory. And that memory response will stay with you for the rest of your life. So if you're ever re-exposed, then whatever the memory is to a specific pathogen, you will be able to respond to that very, very quickly. And then you would not have a second bout of that disease. Memory is the basis of vaccination, where you have a vaccine that mimics a natural response, but the person doesn't get sick, but does develop memory. The major cell type for acquired adaptive immunity, where memory is a response, is going to be your lymphocytes. These are going to be specific white blood cells that mainly reside in the lymph nodes, and they are the type, or they are the cell that is going to be evoked in this particular response. You have two major types of lymphocytes. You have B lymphocytes because they are going to get their education in the bone marrow, and they are going to produce a protein called an antibody. This is a Y-shaped protein that has the ability to bind to a specific antigen and start a process which will eliminate the invader. The other major type of lymphocyte is a T lymphocyte or T cell. It receives its education in the thymus gland, which is near your heart. And when the T helper lymphocyte is activated, then that is going to be able to control the immune response. There are other T cells, like T cytotoxic cells, that are going to be able to be cloned up and attack and kill the antigen. Now, the antigen is that part of the pathogen that is recognized by the immune system as foreign or different. This is a table that is going to summarize the previous slides. So you have your first and you have your second line of defense. Your first is going to be your immediate response by the immune system, and the second is going to be evoked if that is not sufficient. It's the timing of the defense, it's immediate for innate, and for acquired it is a delay. And yet with the delay, you're going to eventually be able to invoke memory. The specificity, broad specificity means that sometimes it's called non-specific, and what they mean by that is that the cells that are involved in that type of response, which are mainly white blood cells, leukocytes, aka neutrophils, which we'll talk about later, they are going to treat all pathogens the same way. So whether it is a bacterial infection or a viral infection or a fungal infection or a parasite, what is going to happen is the pathogen is going to be engulfed by these phagocytic cells and killed internally. In contrast, the acquired immunity is going to be something that is very specific for the pathogen involved. So it would be specific for the influenza virus. It would be specific for the staph infection. It would be specific for streptococcus causing your strep throat. And that is the big difference between the two of them. For memory, your innate immunity is not going to remember, but your acquired immunity is. You will have memory of that. Now the cells involved. I'm not going to go through all of these. I'm going to pick a couple of them from this list. I'm going to first pick on neutrophils. Neutrophils are a type of white blood cell, type of leukocyte, a type of granulocyte that is very prevalent in circulation, and it is involved in phagocytosis of the microbes that have landed in the wound site. The way that they are able to go from circulation into the tissues to do phagocytosis is because mast cells in the area are triggered to release a very active chemical called histamine. And histamine, we'll talk about that in a couple of slides. Over here, the cells that are mainly involved in acquired immunity are your lymphocytes, are your B and T lymphocytes. Okay, next slide. This is a figure, and what the figure is trying to show you is you have an antigen, a pathogen that is trying to invade the body. Here you have your innate immunity, including physical barriers, including chemical reactions. And so this list is all about the inflammatory response. This is what would happen when I pick the knife up the wrong way. So I pick the knife up the wrong way, I've cut through my skin, microbes are entering the wound site, I am going to end up clotting that. I am, however, going to have to draw into that wound area phagocytic neutrophils in circulation, get them out of circulation, get them into the wound area so they can do phagocytosis. So inflammation is the name of the game. And the main thing is that you're going to have these inflammatory mediators like histamine released by mast cells that will allow the white blood cells to do their phagocytosis. If that fails, then that's when the adaptive immunity kicks in. That is going to then address that specific pathogen which is still persisting in the body. And that's where you're going to have the T lymphocytes and the B lymphocytes and their products get involved. And after the elimination of the invader, memory will ensue. All right, now we get into the next section. And the next section is going to be, what is the difference between acute inflammation and chronic inflammation? Acute inflammation is going to be rapid, sudden. It's going to unfold in a matter of days. And then you will have the microbes cleared and you're going to have wound healing and it will be resolved. Chronic inflammation, you're talking about a process that is going to persist over weeks, months, years, perhaps a lifetime of an individual. So here we have acute inflammation, so rapid onset. You can have fever, doesn't happen all the time, but certainly fever is an example. Leukocytosis, great name. What that means is that during the acute inflammatory reaction, you have an increase in white blood cells. And white blood cells are also called leukocytes. And the main leukocyte that is in circulation is the neutrophil. And neutrophils are phagocytic. Acute inflammation also is going to have the mast cells in the area release histamine, and histamine is going to be responsible for the 4 cardinal signs of the inflammatory response, namely swelling, redness, heat, and pain. More about that later. Common inflammatory responses of the acute nature, infections, tissue injury, responses to foreign bodies, like a splinter. You could get, pick something up and you get a splinter in your finger. That's considered a foreign body, and certain immune reactions. Now, chronic inflammation is going to persist over weeks, over months, perhaps years. And the blood count would show that you not only would have elevated leukocytes, but you would also have elevated lymphocytes. A little bit about macrophages and monocytes. They are both phagocytic cells. You don't have a lot of them, but terminology. Monocytes are very large phagocytic cells in circulation. You're going to find them right in the blood. If they move into the tissues, then they are called macrophages. They are also phagocytic. And I know it's confusing, but they essentially are one and the same cell. If you find them in the tissue, you call them macrophages. If you find them in circulation, they're monocytes. Signs and symptoms of chronic tend to be less severe. Now, look at the diseases. DM is diabetes mellitus, atherosclerosis, or COPDs. Also look at the autoimmune disorders of multiple sclerosis. This is lupus, this is Hashimoto's thyroiditis. What do they all have in common? They have in common that they occur as chronic inflammation over years, perhaps decades, in some cases for the life of the individual. I'm going to pick on atherosclerosis as an example. That's going to be plaque formation in coronary arteries. That can occur, that's chronic inflammation for 10, 20 years, where the inflammatory response is persistent, but the person doesn't perceive that they are building up plaque because it isn't large enough. And then eventually you get to a plaque size that is starting to occlude blood flow. And if that is totally occluded, then the person could end up with a heart attack. And that would, if not treated in time, cause injury, death of the myocardial cells. And then they would be replaced by non-functional scar tissue, and the person would be minus a certain amount of cardiac function due to that. But in all of these types of diseases, both in this category and that category, you are going to have a very persistent, ongoing, chronic inflammation that the patient may not be aware of for decades, and then all of a sudden the straw breaks the camel's back, so to speak, and then you've got the silent disease, the silent chronic inflammation expressing itself very rapidly in the form of thyroiditis or lupus or atherosclerosis or diabetes. The table. So the table is trying to summarize everything that we've gone through in the past few slides. So acute inflammation is fast, chronic inflammation is slow. The main cell type in acute are your neutrophils, they're phagocytes. The main cell type in chronic inflammation are going to be the monocytes, the macrophages, and the lymphocytes. The degree of tissue injury, when they say usually mild and self-limiting, what that means is I picked the knife up the wrong way, I cut myself, the area is going to be very acutely painful for a short period of time, and then it's going to resolve wound healing. So relatively speaking, it's fairly mild. On the other hand, chronic inflammation is persistent, it's progressive. The predominant process is going to be vascular, meaning it's going to be blood vessels and those cells contained in the blood. On the other hand, chronic inflammation is going to include things like connective tissue formation, scar tissue formation, things of that nature. And the acute or local signs, when I pick the knife up the wrong way the next morning, it is extremely painful. So that's what they mean by predominant. By less severe coronary artery disease, you don't really perceive it at the beginning. You might not perceive it 10, 20 years out. It might take that long a period of time, so it seems much less severe. That's one of the reasons why they would call it a silent disease. Okay, so the function. What are the functions of acute inflammation? Well, it's not necessarily considered pathological if I pick a knife up the wrong way and I slice through and I clot and then I have an inflammatory reaction and it gets resolved and there's wound healing, then that's a very appropriate acute inflammatory response. We will also discuss throughout the semester that there are certain acute inflammatory responses that are due to very pathological events. Specific functions. I'm going to skip this one. That really should be at the very end of our laundry list, but I am going to talk about, a specific function of acute inflammatory response is prevention of further damage. So the pathogen could be a pathogen that releases toxins. The other thing that you think about the inflammatory response is you're trying to eliminate the microbes in the wound area. So that would mean that once you eliminate them, those pathogens, whether or not they make toxins or not, are not going to damage any more tissue. Another, prevention of the spread of infection or tissue injury. One of the things that histamine is going to do is increase smooth muscle contraction, and that contraction of smooth muscle is a great way of preventing the spread of the microbe from the wound area to other tissues. It enacts kind of a walling off, so it just becomes more difficult for the pathogen to spread. So the smooth muscle contraction is now going to prevent that by walling off the microbe. And it is going to prepare the area for healing. When you have inflammatory cells that arrive at the wound area, they are going to eliminate not only the microbe, injured tissue, dead tissue, and by doing all three, then that is going to mean that when they're cleared, now you can do wound healing. Now you can resolve all of that. Now you can reconstruct that area so that 6 months, I look at the hand, it looks like nothing happened. All right, the cardinal signs of acute inflammation. Latin. Latin. Much of medicine science is Latin-based. A little bit of Greek, but mainly Latin. So rubor, calor, tumor, dolor are all Latin for. So redness, rubor, heat, calor, swelling, tumor, and pain, dolor. So redness, heat, swelling, and pain are the four cardinal signs of acute inflammation. Causes of acute inflammation. Infection. These are all microbes. Tissue necrosis associated with ischemia, I'm going to talk about later when we talk about cardiovascular. So I'm not going to talk at length about that here. Reactions to foreign bodies. I pick something up, I get a splinter, that is a foreign body. And allergic reactions, which are actually based in immune reactions. These are inappropriate reactions. For example, I am allergic to ragweed. So right about now I'm taking a lot of Allegra. And the reason why it's considered inappropriate has to do with the fact that the ragweed pollen is not trying to take over my body. It's not trying to cause disease. It's an inappropriate immune reaction. But believe me, I have histamine being released, and so if I didn't take an antihistamine, then I would be sneezing, coughing, and wheezing throughout the entire time of ragweed pollen being high. So those symptoms of allergies, of these respiratory allergies, is definitely acute inflammation. Okay, vascular events. So vascular means circulation, circulatory, and the immediate response, I'm not going to get into precapillary arterioles. Rather, what I would like you to know is that most of the acute inflammatory response is going to start in the circulation and circulatory system. And what's going to happen immediately after I pick that knife up the wrong way? There's going to be an immediate vasoconstriction. So it's almost as though when that actual act occurs, the blood doesn't gush out right away. It will take several seconds, and then it will start to bleed. And that has to do with an immediate vasoconstriction. That is not going to stay vasoconstricted for a long period of time, but it is going to prevent the immediate gushing out of blood. Now, what will then happen is I will start to bleed, and then there will be a whole series of blood clotting that will occur, and I'm not going to talk about it right now. We actually have an entire chapter on that. But once you've clotted the blood, then the body realizes that there are microbes in the wound area that need to be eliminated, as well as damaged tissue, as well as dead tissue that then has to be cleared before wound healing can occur. The main active pharmacological agent that the body is going to release in that area is going to be histamine. I'm not going to talk right now about the other ones. We'll do that later. Okay, so continuing with our vascular events, the events are going to be mediated by mast cells releasing histamine, and a couple of slides later we'll get into that. The effect of histamine is on many levels. Histamine can cause vasodilation. Histamine can cause increased capillary permeability. Histamine can cause the migration of phagocytic neutrophils to the area. And histamine can also produce factors that can cause the neutrophils to selectively move out of circulation into the wound area. So vasodilation means that the arterioles that are feeding the infected area, let's again go back to my picking the knife up the wrong way, the arterioles in that area are going to dilate. They're going to get very large. That's going to allow a faster migration of phagocytic neutrophils to that area. And it will also cause redness. Why? Because most of the cells in the blood are red blood cells. So picking up that knife the wrong way after it clots, I wake up the next day, that area around that wound is quite red. And so the dilation means is bringing more red blood cells, and so the redness. The other thing is that by evoking and moving as many of these phagocytic cells to the area, that is going to warm that area. And that actually is a kind of a great local response, because as that area becomes warm, it becomes quite microbicidal. So the warmth in that area is good. Redness, right? So the redness and the warmth, the heat, and those therefore are two of the cardinal signs of inflammation, the redness and the heat. The increase in capillary permeability, what is going to happen is, remember, you have arteries, arterioles, capillaries, venules, veins, and then you go back to the heart and it pumps. When you get to the level of capillaries, it's microscopic. They're one cell thick tubes. They're made up of endothelial cells. And because they're so small, because there's only one layer, that's when you can get substances, things like neutrophils be able to get in and out, other chemicals be able to move in and out, respiratory gases to move in and out, glucose to move in and out, waste products to move in and out. So when you have an increased capillary permeability, it means that the histamine binding to those endothelial cells of the capillary, they pull apart a wee bit, not a lot, but enough to allow certain of the neutrophils, these phagocytic cells, to squeeze out and to enter the wound area so that they can do phagocytosis and eliminate the microbes. As a unintended consequence, you also, by increasing that capillary permeability, plasma, the liquid portion of blood, is also going to leak out. Thank God red blood cells do not. they're hard by concave discs, and there's no way that they are going to be able to move out, which is a good thing. But it also means that when you have the plasma be moving out along with the neutrophils, that's going to build up fluid in the tissue area. So that is called edema. And edema is another term for swelling. So when I looked at my hand the next morning, that area is swollen. The other thing that is going to happen is when you do have that swelling in that area, you are going to trigger pain receptors that are going to respond to an increase in pressure. So that area is also going to be painful. So that's the reason for the other two cardinal signs of inflammation, one of which is swelling, the other is pain. By having histamine bind to the capillaries, then you're going to have the major migration of the neutrophils. And the neutrophils are going to be the main cell type in the acute inflammatory response that is going to enter the wound area. You are also going to have other factors that are going to be involved in that capillary bed, one of which are going to be certain receptors that will appear on the endothelial cells that are facing the blood that will then be complementary to receptors on the neutrophils so that they can bind to each other. Think about Velcro. So you're going to have sort of the positive or the Velcro-like neutrophils and the Velcro-like receptors on the endothelial cells, and that will allow the neutrophils to bind to them, and that will enable them to stop moving and to squeeze out and arrive at the infection area and to start phagocytosis. The figure. So the figure is, I call it a kitchen sink figure. It's trying to do a lot of different things. But the thing I don't like about the figure is it doesn't tell you kind of the sequence. So let me first say that one of the first things that's going to happen is thrombosis, blood clotting. And these mast cells, now the mast cells themselves are going to release a lot of vasoactive compounds, but the thrombosis will be activated by other factors and be aided by mast cell chemical release. The other thing that, and again, major thing I'm going to talk about is histamine. Histamine can bind to the endothelial cells of the capillary bed, as well as to the arterioles that are feeding the capillary beds, and that can cause vasodilation. Binding to endothelial cells is going to cause increase of capillary permeability. The infiltration or the moving of the neutrophils from the blood into the tissue is going to be directed by histamine. And because the fluid is also going to move, and you're going to have that area swell, that's going to trigger pain cells. So that's the simulation of the nerve endings. And here we go. So this is a figure showing what some of the chemicals that are released by mast cells are able to do. So what they are able to do, and it would be nice if it showed it binding here, but it doesn't. But these are the Velcro-like things that I was talking about before. So now the endothelial cells are now under the auspices of the chemicals released by mast cells are going to be able to be revealed. The neutrophil is going to be able to bind. And now, because of the pulling apart of these endothelial cells, they're going to be able to squeeze on through and then enter the wound area and do phagocytosis, eliminate the invader. The process of phagocytosis. And I'm going to simplify this. I know that in microbiology, a lot of what I'm talking about in this chapter was covered, so it's a review. And phagocytosis means that the pathogen is recognized, that the phagocytic neutrophil is then going to engulf it. I like to think about phagocytic neutrophils as like amoebas because they were able to change their shape. And so they're able to engulf and internalize the pathogen. And then they have organelles like lysosomes that contain digestive enzymes and poisons, and that then the lysosomes have the ability to internally destroy, kill the pathogen. This is a picture of it. So this is showing you the receptors that the phagocytic neutrophil are displaying that would then allow for the shape change, the engulfment of the pathogen, and eventual destruction. So now what we're going to turn our attention to are the cell types. Now, the cell types are going to be for all types of inflammatory responses. So as much as what I've talked about before had to do with acute, this section is going to say whether it's acute or it's chronic, and it's not going to make the distinction. So in various types of inflammatory responses, what are the various types of cells that you could possibly see? So this is like a review of the different cell types and what they can do. So before it was acute, in a few slides I'm going to end this presentation, and it's going to be part A, because part B is going to be all about the specifics of chronic. So this is just a generalized description of the different types of cells that you can find in different types of inflammation. So, leukocytes are white blood cells. They are going to mainly be neutrophils, these phagocytic cells. So, you have, again, many different ways of talking about white blood cells or leukocytes, and whether you like it or not, you have to understand that unfortunately there could be 5 ways of describing a white blood cell. So here goes. You have lymphocytes, you have granulocytes. Neutrophils are a type of granulocytes. And you have monocytes. And as we had mentioned before, if the monocytes migrate into the tissues, they are macrophages. So we know that lymphocytes are either T lymphocytes or B lymphocytes. And there are another type of lymphocyte called a natural killer. Granulocytes, also called myeloid leukocytes. And they are neutrophils, eosinophils, basophils, and guess what? When you have a basophil in circulation, you call it a basophil. If it is in the tissue, you call it a mast cell. What does that mean? It means that both basophils in circulation have histamine. Mast cells in tissue have histamine. The major granulocytes that are involved in inflammation are going to be your neutrophils, they're your phagocytes, and your basophils or your mast cells, they make your histamine. So the histamine directs inflammation, and inflammation is going to deliver the neutrophils to the wound area so it can do phagocytosis. Monocytes. Monocytes are big cells. You only have about 15% in circulation, but they are fantastic phagocytic cells, and they tend to be called into play after the neutrophils have done their thing first. Again, monocytes are big phagocytic cells in circulation. Macrophages are big phagocytic cells in tissues. Dendritic cells I'll talk about later. Right now I'm going to just put them to one side. Now, we're going to have tables. And these tables are going to be great for coming back to Chapter 11. Chapter 11 is going to be something that you will be looking at over and over again because inflammation raises its ugly head over and over during the semester. This is giving you a lot of detail that I am not going to go into right now. I'd rather go into detail, let's say, of rheumatoid arthritis when we're talking about rheumatoid arthritis, or when we're talking about lupus, when we're talking about it, or when we're talking about multiple sclerosis. So right now, know that these tables exist and that they give you a lot of information, but a lot of the specifics are going to be covered when we go into the different pathophysiologies in the different organ systems. So this is why, mature in the thymus for T cells, acquired immunity. These are cell surface receptors. These are the different types of T cells. Same thing over here with B cells. They mature in the bone marrow. They are in acquired immunity. They produce a lot of antibodies, different types, natural killer cells, right? They're formed in the bone marrow. They can kill tumor cells, and so forth and so on. So right now, what I've talked about with the T cells and the B cells are the only thing that you're responsible for. However, know that it's a much more complicated picture, and a lot of the complexity we will visit in future chapters. Same thing over here. Neutrophils, the most common type of white blood cell in circulation, first to respond, involved in acute inflammation and phagocytosis. So know about these, but we're not going to get into a lot of the specifics until we get into future chapters. So the neutrophils, eosinophils, basophils, and mast cells. So what we've talked about previous, you need to know. The rest of it, no, we'll talk about it later on. Again, same thing for monocytes, macrophages, dendritic cells. And this is a picture that is trying to capture what is happening before, during, after I pick the knife up the wrong way. So when I pick the knife up the wrong way, I'm going to start to bleed. Blood platelets are involved in blood clotting. And then once I've clotted the blood, I've got to get rid of the microbes and damaged dead tissue. So the mast cells in that wound area are going to release histamine, and that's going to bind to the endothelial cells of capillary beds and start all kinds of things. So you're going to have histamine be able to get that Velcro process going so that the white blood cells can marginate along the edges and squeeze on through. And then these phagocytic neutrophils are going to do phagocytosis. A little bit later on, once the microbes in the damaged tissue are removed, macrophages will move into the area and they're going to release a number of chemicals that will start the wound healing process. The term cytokines, what that means is that they are cell signaling molecules. And we'll talk more about them with chronic inflammation, but cytokines is again kind of like a kitchen sink term, which involves all different types of chemicals that are involved in activating the immune response. Okay, so this is going to be the last few slides. And these are going into chemical mediators of inflammation. So mediators are any chemicals that are secreted by cells. They might actually be present in an inactive form in the plasma. For example, everybody has inactive plasma proteins that can get activated when someone picks up a knife the wrong way and needs a clot formed. So you have all of these inactive clotting factors that are only going to get involved in forming a clot if they get activated. So these are what they mean by plasma proteins that are already present versus cells like mast cells that can become activated and release chemicals like histamine. So these are cell-derived mediators like histamine made by mast cells, or plasma proteins usually made by the liver in an inactive form that will then become activated if there is a pathological event that happens in the body. Here we have the lovely tables once again. So you have vasoactive amines like histamine. You have lipid mediators like prostaglandins. You have cytokines, which we'll talk more about, and prostaglandins will also be talked more about when we talk about chronic. Inflammasomes and chemokines I'm not going to talk about right now. And next slide. Complement. I'll talk very briefly about this in a sec. Coagulation, making a blood clot, platelets, and other coagulation factors that are invoked when I pick the knife up the wrong way. I am not going to talk about the kallikrein-kinin system right now. So let me go back to complement. Complement is a system that was most certainly covered in microbiology. Let me make it as simple as possible. It is a system that is going to allow the amplification of the immune response to get a quicker resolution. Complement is actually a number of, it's about 20 proteins. They are in circulation as I speak. They are in an inactive form as I speak. They are going to only be activated if there is an insult, like a microbial invasion. However, the insult can also come from within, like an autoimmune disease. The complement cascade, as it's called, is a fantastic ancillary cascade that will boost the efficacy of the immune response. It is complicated, and the next slide is going to show you how complicated it is. And this is actually the last slide in this particular presentation. I want you to just look at the slide and see how complicated it is. I am not right now going to get into the classical pathway or the lectin pathway or the alternative pathway. There will be some pathophysiological mechanisms in future chapters that very much embrace the complement cascade, the complement system in the unfolding of the pathology. And at that time, I will get into more detail. Right now, I just want you to realize that it is a system that can be evoked that will amplify the immune response. And that's it. So take a short break, and when you feel that you want to tackle part B, by all means do so. But this is Part A, Chapter 11, Inflammation. Thanks. Take care. Bye-bye.